So then we're going to move on, and then we'll finish up in a few minutes, and then we'll get to hopefully lots of questions. But knee surgery, and kind of what does knee surgery or total knee arthroplasty or knee replacement surgery look like in my hands as well as in 2015? Well, it's real helpful for patients that have painful, disabling joint disease that results in severe arthritis. And if you're not amenable to other treatments, or if you've gone through all these other treatments, including anti-inflammatories, injections, braces, you've tried all this injections that you can tolerate, you're tired of being a pincushion, and you're just ready to go to the next level, that's the patients that are really ready for surgery. And I talk to most of my patients, they typically come in and tell me that they're ready to have this done because they've dealt with their knee pain for so long that they're ready to have knee replacement surgery. There are different types of knee replacements out there, including these ones that are called uni knee replacements, which means we just replace a portion of the knee. These are typically reserved for younger patients that have just one portion of their knee being affected by arthritis. Not that you have to be young to have this done, but typically as you get older, there's more arthritis in the knee than just one part. And I'd say, if you looked at joint replacement surgeons around the country, partial knee replacement probably only make up about 5% of their patients. The majority of patients fall into the total knee replacements, and that's typically what we do because, even though these are good surgeries, their track record, they may last for 5 to 10 years, and then you're going to have a full knee replacement after that. So, majority of my patients tend to go for the knee replacement because they just don't like the idea of having to have something else done 5 or 10 years from now. But they are good, and they do have their place, but I tell you, in my practice, it's very limited as far as who I do that for. The patellofemoral joint, that's where your kneecap articulates with the femur bone. There's a small patient population that just have arthritis there, and that's a difficult problem, especially because this type of replacement, it, again, has a good track record, but it's not as good as a total knee replacement. And sometimes you get into a patient's knee and you think it's just arthritis there, but they also have evidence of arthritis elsewhere. You're probably better off having a knee replacement done so that you don't have to go through another surgery 5 or 10 years after that first one. So total knee replacement is what we'll finish kind of talking about, is where you replace all the surfaces of the knee, the end of the femur bone, the tibia bone, as well as the kneecap. And that's what it looks like on an x-ray. So if you look here, these are 2 x-rays of the knee. This is what's called an anterior view, and this is a lateral view. And this is the knee that this is what the knee replacement would look like in my hands if you got x-rays post-operatively. So what happens is we'll probably have a model here that we can either pass around or you guys can get up and look at after the talk, that shows that the end of the femur bone gets replaced by a metal cap, and you can see that on this front view as well as this side view where it wraps around the bone. Whoops, apologize. And again, you're asking, what part of the knee do we take out? Well, you can see we make these cuts on the knee. I basically tell patients, I'm sorry, it's touchy, that I use carpenter jigs, essentially, kind of going back to my architecture days. Basically, you use these jigs that are designed specifically to make these cuts that go around the bone. I'll get my cursor here. And you can see we make 4 cuts around the femur bone so that this cap will sit on the end of the bone. On the tibia bone, we make 1 straight cut so we can realign the leg. A lot of patients come in and they'll be kind of bow-legged. And basically, we're not going to leave you bow-legged after surgery, but we're going to straighten your knees out. We're going to make your knee go back to being where it's supposed to be, which is about 5 degrees of what's called valgus, which is the knee actually angled outwards. And that's 5 degrees is hard to notice on a patient, standing, but you can see that on this x-ray here on the left-hand side, whereas the femur comes down and then the tibia, it does angle out just slightly, if you can appreciate that. And then the kneecap gets resurfaced by what I like to call a plastic button, but it's made out of the same material as the plastic between the 2 pieces of metal here, and it articulates with the femur here. So the space, the space that you see between the 2 pieces of metal, I think there's a ghost up here. That space that you see between the 2 pieces of metal here and here is the plastic. I call it plastic, but it's polyethylene. It looks like plastic, but it's fancy plastic, so to speak. It's where a lot of the technology has come now in 2015, where we can say that hopefully these knees, once you have it placed, will last somewhere about 30 years because they've got this plastic now designed to last that long. And they take these knees and they put them in a laboratory and they cycle them, 15 million times, which would represent walking on the knee for 30 years. And then they look at that polyethylene or that plastic and they show that it hasn't worn out. And the same idea hopefully holds true once we put these inside a patient's body, that the same thing would happen as it does in the lab, that they would last for 30 years. Again, barring any unforeseen complications.